mic'd. Great. So I'm Shanti Eswaran. Thank you so much for the introduction. It's my pleasure to be here this afternoon to talk to you guys about IBS and the non-pharmacologic management associated with that. These are briefly the learning objectives here. I won't go over those too much, but I'd like to start off with this quote. A good, reliable set of bowels is worth more to a man than any quantity of brains. And this is from the American humorist Josh Billings. He had a lot of sort of pithy comments, but this is the one that I thought was most apt. But I think we all can take this to be true, right? That if you're not feeling well in your gut, then you cannot be your best self. And this is something that we, as clinicians, just hear from our patients day in, day out. So functional GI disease is a lot like Crohn's disease. It can affect anywhere from the mouth all the way down. IBS is the most common, and so you'll hear me talk mostly about IBS. But a lot of the treatments that we can use for irritable bowel syndrome can be applied to any of these functional GI diseases. So what does that mean? A functional GI disease is an idiopathic GI disorder with no anatomic or histopathologic abnormality that can be found on diagnostic testing. So there's no biomarker or blood test or something that we can see on endoscopy that can diagnose functional GI disease. IBS is the most common GI disease we see. It has a global prevalence of about 7 to 30%, highest in South America. In the US, we usually talk about 7 to 10% of the general population having at least mild to severe IBS. It occurs more often in women, and it's also not just very common in GI clinics. About 1 in 20 PCP visits often are from IBS. So the burden of illness in IBS patients is abundantly clear. Patients with IBS have a reduced quality of life that's usually stemming from pain, fatigue, and then their altered bowel habits. It has a reduced quality of life really similar to that seen in end-stage renal disease and even diabetes. So it's a chronic disease that is and should be taken seriously. IBS patients have a reduced work productivity, usually due to, again, abdominal pain and fatigue associated with the disorder. Patients with IBS also have increased incidence of surgical procedures. So all of this amounts to major costs to society with $20 billion annually in direct and indirect costs. So the diagnosis of IBS is a symptom-based disorder, and we'll talk about what the Rome 4 criteria are in a moment. But you need to fulfill both the diagnostic criteria as well as the select exclusion of organic diseases. And we can easily do this with a couple of blood tests. So a complete blood count, CRP, as well as the evaluation for celiac disease. And endoscopy and colonoscopy are not necessarily required, but often done. But there's no role for stool testing, food allergy testing, and a lot of other testing to make sure or really confidently say that a patient has irritable bowel syndrome. So what are these Rome 4 criteria? Basically, every so often, a bunch of experts in the field internationally come together in Rome to talk about what makes an IBS patient an IBS patient. And this is the 4th iteration of these criteria. And it requires that recurrent abdominal pain at least 1 day per week in the last 3 months associated with pain related to defecation, pain associated with the change in frequency of stool, as well as form of stool. So when I see a patient, I'm not checking the box to see if they have all of these things. This is really for research. But I want to know, is their pain chronic? Is it related to stool in some way? And then if they have those things, I'm generally thinking that they have irritable bowel syndrome. You can also subtype a patient with IBS based on their stool consistency. So some patients with IBS have about 75% of constipated stool type, so they're IBS-C, similar to IBS-D, and then there's a mixed subtype as well. But it's important to note that patients can go from one form to the other, and that's not necessarily a cause for concern or a cause to repeat their workup. But it's just kind of something that's like a natural progression of the disease in some people. Often, too, it's important to note that patients, say, with IBS with diarrhea will still have 20% or 25% of the time where they don't have diarrhea. They can have normal stools or constipated stools, and that's a normal part of the disease. So what does IBS look like? So loose or frequent stools, constipated stools, but bloating is a main component. Patients will often describe how much this drives them crazy. So abdominal cramping or discomfort, stool urgency, but also their symptoms may be brought on by just food intake in general, so just eating can cause symptoms, or specific food sensitivities. And also changes in their symptoms really can occur over time. So it can go from left upper quadrant to left lower quadrant, and that's a normal thing. Their stool patterns may change from constipated to diarrhea and then back again. So all of these are like normal features of the disease. But some features that are not part of IBS or that should be concerning are symptom onset after age 50, severe or progressively worsening symptoms, unexplained weight loss, symptoms at night, and also any family history of organic disease really should be, we should really go down that path to making sure they don't have those things. Certainly, rectal bleeding, melena, and unexplained iron deficiency are not characteristic of IBS. So why do we have this? What causes IBS? There's kind of been an evolution in the mechanistic hypothesis of this over the years. So back in the 50s, we were talking about abnormal motility. So the gut was going too fast or too slow. And then in the 80s, we were talking about visceral hypersensitivity. The gut is just too sensitive. And then we started to talk about the brain-gut interaction, and we just heard about serotonin and visceral sensitivity and gut motility. And in the last 10 years, it's been more about diet, microbiome, and also the role of post-infection IBS. So we have a lot of medications available to us to treat irritable bowel syndrome, and they're often very symptom targeted. So here are kind of like the three main complaints that we see related to IBS. And if a patient has, say, their main complaint of bloating, we might use a probiotic or antibiotic if we're trying to think of a medication. If you have diarrhea or constipation, you can use certain medications to target that. So over-the-counter antidiarrheals or prescriptions, or prescription-based laxatives or over-the-counter laxatives are often used to treat their altered bowel function. And then for pain, antispasmodics, peppermint oil, and then also the use of antidepressants are often used as medications to treat the pain related to IBS. So using these standard medical managements for IBS, how do these patients do? Well, the answer is not very well. Most patients with IBS are still symptomatic after we try to treat them with our medication. So only about 22% of patients report significant improvement in their GI symptoms after 6 months. There are predictors of worse outcomes of who won't get better. So those with prior surgery, patients with a longer duration of the disease or higher somatic scores, and also patients with comorbid mood disorders of anxiety and depression aren't going to do as well. So there's this clear need for supplemental interventions. And it was really, my interest in this area really came out of the first 2 years after my training. I was seeing a lot of IBS patients as a young female gastroenterologist, and I couldn't help them with any of the medicines. I was getting really frustrated. And so I started looking at other non-pharmacologic things that we could do. So that's how I got interested in diet as well as some sort of psychotherapies related to IBS, which we'll talk about. So when we talk about IBS treatment, at the bottom we often first, for mild symptoms, talk about, okay, modify your diet, what are your trigger foods, certain lifestyle advice, which we'll talk about, but also giving them a name for their symptoms can be really powerful. So giving a patient a very confident diagnosis saying, I think you have IBS, I know this because of all of these things that we talked about in the test that we did, and explaining their symptoms, offering them reassurance that this is not necessarily anything bad or dangerous can be really, really helpful for patients with mild symptoms. Patients with moderate symptoms is generally when I start to see them in my office. We talked about the importance of regular follow-up, managing their stress, and this is where we start to use some of the medications we discussed. And those with severe symptoms can be also very challenging, as many of you know. And here the focus is not on cure or total improvement of their symptoms, but the focus is on improving functioning. So here we go about this with a continued therapeutic alliance, so non-abandonment of them, and also offering psychological treatments that we'll discuss. So the lifestyle advice that I mentioned, some of these do have data supporting them, but the importance of regular exercise, regular sleep, avoidance of caffeine, regular reasonable meals, and also avoiding known dietary triggers, which is sometimes very difficult, are all definitely worth trying. I mean, it's very common sense, but most of us don't do all of these things in here. I mean, I don't get regular sleep. I mean, I'm not always avoiding things that I know are going to make me feel ill, right? I mean, we just don't do it. And so telling people that trying to have a regular schedule, trying to be more rigorous in all of this will help your GI symptoms, I think can go a long way. This is a study that looked at the impact of physical activity on IBS. This is 102 patients who were randomized either to no activity or somewhat rigorous physical activity over a 12-week period. And here on the right, you can see that there's significant improvement in their IBS symptom severity score at the end of the study period, kind of, again, giving credence to the notion that regular exercise will sort of cure what ails you. I mean, if you can't sleep well, try exercising. If you're a little bit depressed, try exercising. But it's going to help. So there's really no downside. But let's get to diet as treatment of IBS, because I think that's definitely what I'm most interested in. As we mentioned, the market forces and the available drugs have really limited the drug development of these so-called quality of life disorders, such as IBS. And therefore, we have drugs that really have limited efficacy at best. But traditionally, diet has been kind of a black box for us as clinicians, and we don't have a lot of training. It's viewed as kind of fringy or non-scientific. And there's no evidence-based strategies, at least until the last 10 years, that could show that a certain diet may improve IBS symptoms. So it's really been our patients that have been driving research on diet and lifestyle IBS treatments. So how does food cause GI symptoms? Patients may have a food intolerance, certain psychological factors. Patients with IBS may have impaired gas handling. Certainly changes in microbiome or fermentation patterns could be playing a role. IBS patients have an exaggerated gastrocolic response, but regardless of all of these reasons, we know that up to 2/3 of patients with IBS associate their symptoms with eating, whether it's eating a certain type of food or just eating in general. So how does this occur? Well, food has primary and secondary effects on the GI tract, and these are normal and these are physiologic. And they're kind of listed here. They can happen to both automatically and quickly, or as the food moves down the GI tract, it's fermented, and then in the colon, which changes luminal pH, changes microbiome, and also changes bile acid metabolism. This then layers upon an IBS GI tract, which is, as we talked about, isn't normal compared to healthy controls. It's this GI motor and GI sensory dysfunction that an IBS patient has that then interacts with the primary and secondary effects of the GI tract to cause IBS symptoms of pain, bloating, and altered bowel movements. And it's this kind of poor understanding that is really like a major force in GI research right now. So right now, when we're talking about a patient with IBS, we try to make a confident diagnosis, tell them they have IBS, and offer them some therapeutic reinsurance in that way. We discuss the brain-gut interaction, and then we talk about what to do next. So in my practice, I talk about diet, psychological, and then adjunct therapies. In diet, we talk about a low FODMAP diet or other strategies like a gluten-free diet, perhaps. For psychological treatment, we talk about cognitive behavioral therapy and hypnotherapy. And then with others, we use medications, and then we can also use strategies to manipulate the microbiota. So when we talk about traditional dietary advice, what we were doing, say, 15 years ago, we really weren't doing anything. We were telling people to avoid excess of things, so avoid caffeine, avoid chocolate, avoid fatty food. And then we'd tell them to eat other things. So don't do this, but do this. So maybe increase your fiber, reasonable meal sizes, don't rush it. Not very scientific, and nobody was really getting any better. But recently, a diet low in FODMAPs is gaining a lot of popularity for the treatment of IBS. FODMAPs is kind of a clunky acronym for fermentable oligodimonosaccharides and polyols. And this restricts the intakes of food high in FODMAPs. FODMAPs are short-chain carbohydrates that are poorly absorbed in the small intestine so that they then go to the colon where they're fermented. And we think that a low FODMAP diet can improve IBS symptoms. And here's a table of some low FODMAP examples or high FODMAP examples. There's 5 FODMAP categories. And you can see, like, for example, many summer foods, like watermelon, are high FODMAP. High fructose corn syrup is, of course, a FODMAP. And you would also notice that onion, garlics, and wheat, which was, I think all of them were in my sandwich before I came in here, it was basically a very high FODMAP lunch. So this can be done, but it's not that easy, and we'll talk about it. How do FODMAPs cause GI symptoms? So this is kind of a crazy schematic about how we think FODMAPs may cause symptoms. Primarily, they're fermented. They go through the small intestine where they're fermented in the colon and have all kinds of downstream effects. Basically, gas production is a big one, which then can go down and cause symptoms of pain, gas, and bloating. And then short-chain fatty acids are then produced after fermentation and have a whole lot of downstream effects as well. FODMAPs can also have osmotic effects in the small intestine. And this is kind of a running thought about what we think is going on when a person, either with IBS or with a healthy control, is eating something in this category. But it's becoming more clear that not all FODMAPs exert similar effects on the GI tract. There's some really elegant recent functional MRI work that looked at 16 healthy controls who ingested 3 different substrates: glucose, fructose, and inulin, which is fructan. And they underwent MRIs hourly for the next 5 hours, and here they were able to assess gastric content, small bowel water content, and then colonic gas volumes. And here you can see with the injection of fructose, there was an increase in small bowel water content that was only seen after the ingestion of fructose. So here, after the injection of fructans, for example, there's really a significant change in the small bowel water content after the ingestion of fructose, which may explain some of the bloating, for example, after somebody with IBS ingested something with fructose. Similarly, fructans or inulin distended the colon with more gas than fructose. But interestingly, given that this was a healthy control group, very few symptoms were invoked in this population. And we know now that patients with IBS as well as healthy volunteers have very similar fermentation patterns. So here on this side, this is after the ingestion of fructose. You'll see an increase in small bowel water content in both patients with IBS and healthy controls, so a very similar look. And similarly on the right, you see an increase in colonic gas volumes after the ingestion of inulin in both healthy controls and patients with IBS. So fermentation patterns seem to be very similar between the two groups, and so that kind of lends credence to the fact that FODMAPs cause symptoms in IBS patients through visceral hypersensitivity rather than altered fermentation patterns and gas production. There's other ways that FODMAPs might cause symptoms in IBS, and one of them may be immune activation. This is a study that looked at 20 patients with IBS, and they were put on a low FODMAP diet for 3 weeks. And all of their IBS symptoms got better. But what was the really interesting thing is that several levels of pro-inflammatory cytokines also decreased. So here, levels of IL-6 and IL-8 increased after 3 weeks of a low FODMAP diet, suggesting that immune activation may be a mechanism by which a low FODMAP diet helps symptoms in some patients with IBS. So moving from mechanism to efficacy, this was the original study from Australia, Monash University, looking at a low FODMAP diet versus a standard Australian diet in IBS. This is only from 5 years ago, and this was the first RCT that was published. So I think it's really interesting and amazing to me how quickly our field has moved in this direction. It's a relatively small study. It's a 3-week crossover study putting patients on either a low FODMAP diet or a traditional typical Australian diet, and all the food was provided. But you can see here by day 7, the low FODMAP group experienced significant improvement in their overall IBS symptoms compared to the typical Australian diet. And this effect was mirrored in both bloating, abdominal pain, as well as passage of wind, which I guess is Australian for flatulence. I don't know. I always think that's funny. It's a really small study, though, and all the food was given to them. There were some blinding issues, and it was a really homogeneous Australian population. And so our group and several other groups internationally wanted to kind of explore this further. And so We embarked on this study looking at the efficacy of the low FODMAP diet compared to traditional dietary recommendations for IBS. And our traditional recommendations were based on modified NICE guidelines from the UK. And it's basically common sense. So our control group, per se, was we told them to avoid trigger foods, small frequent meals, and have caffeine and alcohol in moderation. So really kind of common sense recommendations. The primary endpoint in our study was overall relief of global IBS symptoms. And here you can see that the patients on a low FODMAP diet had about 11% benefit compared to those on traditional dietary recommendations. And this 11% difference was noticeable, but was not statistically significant. However, when individual symptom scores of abdominal pain were looked at over time, the low FODMAP diet, by the first week, but definitely by the second week, the low FODMAP diet group experienced significant improvement of abdominal pain. And similarly for bloating scores, right away we found a significant improvement that persisted throughout the study period. We were also really interested in quality of life measures. So we utilized the IBS Qual, which is a validated survey instrument that looks at disease-specific quality of life. And we found that the low FODMAP diet was associated with patients on a low FODMAP diet basically were more than twice as likely to experience meaningful improvement in their quality of life compared to traditional IBS recommendations. Similarly, we found that the low FODMAP diet lowered anxiety scores compared to standard recommendations, basically after the low FODMAP diet for 4 weeks. And we also looked for depression, but we didn't see any difference with that. So at Michigan, we're really excited about the low FODMAP diet. We believe in that, but not everybody does. And so several investigators wanted to do a meta-analysis, and they looked at 7 RCTs comparing a low FODMAP diet with various controls. This was recently published, and they found that a low FODMAP diet was associated with reduced overall symptoms compared to controls. But when they looked at the 3 biggest studies, there was a much less effect. And the overall conclusion was that the quality of the data was very low. And that's because most studies in this space are at high risk of bias, and there's a lot of heterogeneity among the study designs. And it's hard to estimate the degree of effect given the data we have. So when we talk about a low FODMAP plan, there's really 3 phases. The first is the elimination phase. And I view this as like a diagnostic test, so you can identify if your patient is FODMAP sensitive. And this elimination phase is the beginning, not the end of a low FODMAP diet. It usually takes about 2 to 4 weeks to see if there's any improvement. Only if there's improvement do you go on to the reintroduction phase. And the idea of this phase is to diversify the diet to overall enhance adherence long term, and also to avoid the potential risks associated with a low FODMAP diet. And this is generally about 6 to 8 weeks. And then if you can get through the reintroduction phase, you then enter the maintenance phase or personalized phase. And you use the data that you got from the reintroduction phase to develop a personalized version of a low FODMAP diet. And one can stay on this indefinitely. So looking at this another way, the first phase is the streamlining phase. So here you can see your FODMAP intake is high, and also your GI symptoms are high. During the elimination phase or streamlining phase, you take out FODMAPs, and hopefully your GI symptoms improve. So if you're feeling better at that point, you then start to do the reintroduction phase. Here, slowly introducing different types of FODMAPs to your level of tolerance. Some FODMAPs will be associated with a spike in GI symptoms, and some will not necessarily. And then during the FODMAP personalization phase, you can enjoy a higher level of dietary FODMAPs and hopefully a lower level of GI symptoms. So to make this diet work, you really do need to have adherence, and adherence is key to success. And so we like to use dietitians, but if you can't use them, it is possible to navigate the space on your own, but it can be hard. And that's because there's a lot of hidden FODMAPs in our food supply. We have a lot of packaged foods that have hidden FODMAPs. We tend to eat more, so we have a lot of, if there are FODMAPs in a certain type of food, we're going to eat more of them if we're eating a higher portion size. And also our lifestyle, we really place a lot of demand for convenience. So here's a few examples. This is gluten-free bread, which is generally thought to be okay to eat if you're on a low FODMAP diet. But this contains inulin and honey, which are very high FODMAP ingredients. Similar with yogurt, it also contains chicory root fiber or inulin. These are generally added to make something more higher fiber. And then even condiments are common culprits in using high fructose corn syrup and onion powder. So, eating whole foods can be helpful, but trying to go for packaged things can be definitely more challenging. So some key points. Teaching is ideally provided with the assistance of a trained dietitian. But if you don't have access to that, there are appropriately vetted resources that can assist with implementation. A 2 to 4 week trial is usually sufficient to gauge clinical response in that elimination phase, and about 40 to 70% of those patients will get better. I think it's important to remind our patients that the full low FODMAP diet is not intended to last indefinitely. And it's also not intended for people who do not have GI symptoms. It's not a healthier diet necessarily, and it shouldn't be recommended for people who feel well from a GI standpoint. So moving from FODMAPs, which are carbohydrates, to gluten or a protein, it's just everywhere, right? We have high-profile celebrities as well as elite athletes who are really cutting gluten out of their life to elevate their game in some way or another. But many people don't just use gluten avoidance to increase their productivity or increase their performance. They're often using it to get better from something. And so mood disorders, people are using a gluten-free diet, brain fog, fibromyalgia, and of course, irritable bowel syndrome. But it's defined as reaction to gluten in which neither allergic nor autoimmune mechanisms can be identified. And this is a condition distinct from celiac disease, but it may be indistinguishable from IBS. There's no reliable biomarker. We cannot diagnose this with a blood test or imaging, but it's really important to identify these people when possible because their treatment is eminently different from that of, say, just regular non-gluten sensitive IBS. And we don't know the prevalence, being that it's difficult to diagnose. This is a study that really for the first time demonstrated that gluten could cause symptoms in IBS patients without celiac disease. This was about 30 patients who these Australian researchers put their patients on a gluten-free diet. And if their symptoms were controlled, they then randomized them to either a gluten-containing diet or a gluten-free diet for the next 6 weeks. And you can see here, patients on a gluten-free diet or patients on a gluten-containing diet, even within the first week, experience worsening in their IBS symptoms. But you would also notice that even patients on a gluten-free diet, even though nothing was changed, even seemed to worsen. And this would suggest that if patients maybe thought they were potentially getting gluten into their diet, there was some nocebo effect associated with that. Also, there were significant differences seen for the individual symptoms of bloating, pain, and even fatigue. But is gluten really the culprit, right? I mean, there's so many things in wheat besides gluten. It's just one component of wheat. So wheat contains proteins and other carbohydrates. Alpha amylase trypsin inhibitors, or ATIs, are also contained in wheat, and these are proteins that are known to have pro-inflammatory effects in the GI tract and elsewhere. And also, wheat contains fructans, which is a very potent FODMAP. So it's very likely that that all of these things together may be contributing to GI symptoms rather than the gluten itself. So a group of researchers, the same ones as before, wanted to really figure out if it was the wheat associated with GI symptoms or the gluten in the wheat. So they looked at this concept of non-celiac wheat sensitivity versus non-celiac gluten sensitivity. So they put all these IBS patients on gluten-free and a low FODMAP diet. So that would be difficult, but I guess you could do that. So they put them in there and they were doing better. And then they took them and they randomized them to either high gluten, low gluten, and placebo. So there was no wheat in this diet. It was basically just the gluten protein. And as you can see, that in the first week, and then even going on into that study period, but even within the first week, all the patients slowly did worse over time. So they did worse regardless of how much gluten was added, and there were similar effects on the individual symptoms of pain and bloating as well. And so what they thought was that it's really wheat component rather than the gluten component that was really driving the GI symptom generation in this patient population. So some of the proposed mechanisms of non-celiac wheat sensitivity could be via the fructans, or gluten-mediated, or even the ATI-mediated. But there's also this nocebo effect that I think is really important to understand when we're talking about food related to GI symptoms, and we'll talk a little bit more about that later. So there's been a meta-analysis looking at a gluten-free diet in IBS as well. And essentially, the conclusions was that a gluten-free diet is associated with reduced global symptoms compared to a control diet, but this effect was non-significant. And they stated that there was insufficient evidence to recommend a gluten-free diet to reduce IBS symptoms at this time. So what about manipulating the microbiota for GI symptoms? So we have prebiotics, probiotics, and postbiotics. Most of us are familiar with probiotics, which are live microorganisms that confer a health benefit on the host when dosed adequately. Prebiotics are dietary substances that nurture a selected group of microorganisms living in the gut. Symbiotics combine these, and postbiotics are the metabolic products of probiotics. And these really have been investigated a little bit, but not to the extent of probiotics. There was another recent meta-analysis that included 111 relevant citations, and there's really few prebiotics that can be looked at. But one of the highlights that I pulled out here is that the authors thought that combination probiotics were the most effective. They were able to be assessed in 21 RCTs in about 2,000 patients, with a number needed to treat about 7. So really comparable to a lot of IBS medications that we use. So going back to our pyramid here, we're talking about now, we talked about diet, and we're now going to talk a little bit about psychological treatments. I've talked a lot about how diet in the last 2 sections, but there are some people in whom diet is the wrong choice. A dietary recommendation like an elimination diet can really precipitate eating disorders in the vulnerable. So those with a history of eating disorders would not be someone you would offer this kind of treatment to first line. It can also exacerbate nutritional adequacy in the chronically ill, because a low FODMAP diet, for example, is fairly low in calcium and fiber. And also we see in this patient population something called orthorexia nervosa, which is this obsession with healthy eating. And it's different than anorexia nervosa in that there's really no preoccupation with body dysmorphism or weight loss. But this is in these people, you see this accumulation of dietary restrictions leading to a lot of anxiety about food intake and food avoidance. Food and meals become a primary focus. You get this compulsive checking of ingredients listing, almost like a obsessive compulsive type behavior. And this leads to a lot of distress when unhealthy foods are consumed, or if this is the only type of food that's available. And there's a risk of malnutrition due to the severe restriction in the diversity of foods that consumed. We're also seeing something called avoidant restrictive food intake disorder in our clinics, or ARFID. And this is kind of on the same spectrum, but this is limited food intake based on past negative experience with food. So it's not the health benefits associated with it, but it's really, this is driven by past negative reactions to food rather than an obsession with health. These patients have a very short list of safe foods. So many of you may have seen, I have a patient who can only eat potato chips of a certain brand, baked, unseasoned chicken breast, and diet Lipton iced tea. 3 things. And even water, she says, gives her a reaction, because probably one time she had a reaction after drinking water. It's really, really difficult to treat. This is, of course, associated with weight loss. Sometimes these patients end up on tube feeds, nutritional deficiencies, and psychosocial interference. And so trying to find a specific type of provider to treat this can be a challenge. We do have some experience with this at Michigan. There was a recent abstract our group put out looking at 300 patients who were screened in our clinic. About 20% of them did screen positive for avoidant restrictive food intake disorder, or ARFID. And so we're going to be seeing this, I think, more and more. So the comorbid psychiatric disorders in IBS, I think we're all familiar with that. Almost all patients with IBS have some common some concomitant psychiatric disorder. Panic disorder is often seen, generalized anxiety, depression, and this is associated with worse disease severity in both the IBS as well as the comorbid mood disorder. And so why do we really think this happens? Well, we know that early life trauma is more common in IBS patients compared to the general population. Here in the green is our IBS population, and this is general trauma, but also a history of physical punishment in childhood, a history of emotional abuse and sexual abuse, and this differential between healthy controls and IBS patients is most pronounced in the female population. So the presence of this early adverse life events impacts the prevalence of IBS, but also impacts IBS disease severity. So the severity of trauma that one experienced in childhood correlates to IBS severity, and also the higher numbers of trauma or the higher numbers of early adverse life events both increases symptoms and IBS severity. And there was also new research that demonstrated, not surprisingly, that current adverse life events like a sexual assault, domestic violence will also negatively impact symptom severity. So this is the conceptual model for the development of IBS, okay? So using some of these psychosocial risk factors. So in a genetically predisposed individual, they may experience an early adverse life trauma or an adult onset trauma, as we discussed. But then there's often kind of another trigger or a second hit. So a GI infection, a course of antibiotics, a patient undergoing surgery, or an ongoing psychosocial stressor that's occurring, but not necessarily like a traumatic event. This then leads to more severe IBS symptoms and then symptom-related anxiety. So anxiety about their symptoms making their symptoms worse. This is all related to the bidirectional impact of the brain-gut axis, or this emerging field of psychogastroenterology. So a healthy gut can down-regulate normal gut experiences. So I might feel a little rumbling, but our brain says, no, there's nothing wrong here. Go about your day. But in a patient who has stress or has irritable bowel syndrome, their brain-gut interaction is not able to do that. And so their ability to down-regulate normal gut experiences is compromised. So looking at this with an example, this is a 42-year-old woman with a history of anxiety, IBS, and also a relatively recent small bowel obstruction requiring surgery. So she complains to you of intermittent frequent abdominal pain, and it's really progressing to the severely disabling central mediated abdominal pain syndrome. And you talk to her, and she does have a history of domestic violence, but she feels safe now in her current relationship. And she also has a history of emotional neglect in her household growing up. She perceives her current job as stressful and feels very undervalued at work. So her risk factors are her childhood experience, and then her trigger factors are the surgery from the small bowel obstruction and this ongoing stress. And so she starts to wonder every time she feels some abdominal pain, is this another small bowel obstruction? Am I going to need time off from work and get fired? And this is perpetuating, leading to this very unhelpful kind of vicious cycle. And so this is where psychotherapy can be really helpful. Cognitive behavioral therapy is a very structured form of psychotherapy, and this is the type of psychologic treatment that's been studied most in irritable bowel syndrome. It's generally relatively short, so 6 to 12 treatments, and it focuses on the present situations in which one's symptoms occur rather than one's past mental history. So here, the therapist focuses on maladaptive thoughts that are the causes of these symptoms, and then cause anxiety and depression, which then in turn exacerbate or worsen the physical symptoms. So here's an example. We can start here. A patient may experience some initial discomfort, some diarrhea and abdominal pain. She then may say, oh, like here we go again, it's happening, it's another bad day. And then she starts to get very anxious and frustrated, leading to sympathetic arousal, which then worsens the GI symptoms. And so these unhelpful thought patterns and catastrophizing thought patterns will be kind of fixed and remedied with cognitive behavioral therapy. This is the most, as I said, the most commonly studied form of psychologic treatment for IBS with over 30 RCTs. The number needed to treat here is 3. This can be very similarly compared to gut-directed hypnosis with 11 RCTs and here with an NNT of 2. And I'd like to just compare this to linaclotide, which is a very expensive laxative for IBS, here with the number needed to treat of 7, and rifaximin, which is a very commonly used antibiotic for IBS with an NNT of 10. So patients are spending a lot of time and a lot of money on treatments that aren't working compared to psychological treatments that may be more helpful in a certain patient.